So let's look at this globally. So as far as deaths worldwide, there's 2 million deaths annually, and those are mainly attributed to cirrhosis, viral hepatitis, and liver cancers. You can see that it's the 11th leading cause of death globally. 1 out of 3 are females. And sadly, alcohol is that lead culprit for cirrhosis globally. I think we kind of already knew that, but especially as the years have gone by and with COVID, there's been a big uptick in drinking. So in looking at metabolic risk factors and our aging population, we can suspect that there's going to be more of a burden for advanced MASLD, which used to be NAFLD, which we used to call fatty liver disease. And I'll tell you exactly what MASLD stands for. It's metabolic dysfunction associated steatotic liver disease. So say that 5 times fast. I literally had to write it down because it just came about in July where the AASLD came up with this new nomenclature. And a lot of it is to be more accepting and to not have that stigma of fatty liver. So when you see MASLD, know that that's what that is. And it'll look really smart if you start including that in your notes, because I still see fatty liver or NAFLD, but just put it in there. I put it in my note the other day and I felt so proud of myself. So in the United States, as far as liver disease goes, you can see $32.5 billion is spent in the cost, and the burden of that comes from the emergency room, about 2/3 of those cases. And then about 4.5 million adults have been diagnosed with liver disease as of the most up-to-date data from the CDC. If you look at ages 65 to 74%, we have about 3% of the population in the United States that are dealing with liver disease, and then 1.4% for 75 and older. So our favorite population, the older adult. So what happens as we are aging? So the liver mass is going to decrease about 20 to 40% with aging, and you're going to have that perfusion, that blood flow affected as well. Older livers, they're less likely to tolerate any of those ischemic injury or events that happen. And then you can also see that your liver chemistries are not going to be hugely affected with age. You might see the ALT actually decreased some. So when your patient comes in and you notice abnormal liver chemistries, then you know, hey, it's not an age thing. There's actually something really going on. The serum albumin declines with aging, and also you have that drug clearance that's slower. And then you have the decreased synthesis of clotting factors, increased gallstones, and decreased liver regeneration. So isn't that lovely, like all this to have to deal with? Bless it. So the patterns of abnormal liver chemistries. This is the cool part, because it can be helpful, and then again, it can be very confusing, and I'll tell you why in a second. So you can have a hepatocellular where you're mainly having the AST and the ALT that are disproportionate to the alk-phos. You can have the cholestatic, which is just the alk-phos is more disproportionate to your transaminases, or you can have the isolated hyperbilirubinemia, where you have the normal AST, the normal ALT, the normal alk-phos. The cool thing is the R value, which is also called the R factor, and you can find that online. It's called MD Calc, and there's a link at the end of the presentation where you can put in all those numbers, and there's calculate, meld, all that fun stuff. So we have it, saved on our computers. So sadly, bilirubin can also be elevated in hepatocellular or cholestatic. So it's not a very good, reliable piece of information to look at. And then sometimes they're all elevated, like every single last one of them. And so then you're like, well, now what? And so in that case, you're going to go with whatever is most elevated, your AST or ALT or your alk-phos. So is it predominantly hepatocellular, predominantly cholestatic? So this is not an exhaustive list, but what really sticks out to you about the one on the left column with the AST greater than ALT? What's the first thing that you think of when you see that disproportionate? You can just shout it out. Alcohol, yes. So that's our first clue that I'm always like, do you drink? Well, no. And then you start asking, and sometimes I'll say, well, I enjoy like a nice red in the winter. And then they're like, oh yeah, me too. Actually, I drink this. So I'm just trying to open the door to be like, this is a judgment-free zone here, okay? So you can see there's common causes of AST disproportionate to ALT. You've got your ischemic hepatitis, acute Budd-Chiari. I'm not going to list all this out again, but this is something that you can reference in the future that you can just maybe keep on a little slide deck. So with elevated alk phos, again, not all inclusive, you have what's related to the liver or non-hepatic, and you can see those lists there as well. Again, I'm not going to go through all of that because we're going to be going through that more in depth. I do want to mention their non-hepatic cause of elevated alk phos would be increasing age, predominantly in those women. So elevated bilirubin. Gilbert's, it's my favorite. So if you see an elevated T-bili, total bilirubin, and an elevated indirect bilirubin, we automatically think Gilbert's syndrome. And a lot of times people will freak out or will get referrals from primary care saying their bilirubin is updated, Lord have mercy. Their bilirubin is elevated, and they put them through the $1 million workup, and I end up telling them, well, you have this fancy thing called Gilbert's syndrome, and so just always remember that. Of course, you're going to want to exclude other causes, but just keep that in the back of your mind. And then, of course, if your direct bilirubin is elevated, along with the obviously with the T-bili elevated, you can see the list on the right. I won't list those out for you, but just as something good to keep in the back of your mind. So diagnostic pathways. So what happens when you have those abnormal liver chemistries? I always have to remember I'm just going to follow that yellow brick road. I'm going to follow that pathway that the good old ACG has outlined for me. And sometimes I'll print out that good old paper and I'll look through it, and it's this beautiful schematic of if this, then this. It's pretty much foolproof. It's awesome. We're always going to do a good H&P. That's what we do really good, right? Really well. We listen to the patient. You're going to take care of getting rid of any of those hepatotoxic medications. Of course, discontinue alcohol. And you're going to assess for fatty liver or any viral hepatitis risk factors. So you will always do this at the beginning anytime you see elevated liver chemistries, no matter how elevated they are. So if you have mildly elevated transaminases, which would be less than 5 times the upper limits of normal, you're going to grab that CBC, CMP, you're going to check the Hep B serologies, check that hepatitis C antibody. There's a lab that actually reflexes to a PCR so you can have a viral load, because if it's positive, you want to check to see, is this a chronic infection or did they clear it on their own? You always want to check that iron panel. You might be worried about like iron overload, and then grab a good old ultrasound of the abdomen. So a lot of times you can just follow this, and if all of that is negative, kind of observe it, and then in 3 to 6 months, repeat that CMP. And if it's still elevated, then you're thinking, okay, there's something else going on here. So we're going to check the ANA, we're going to check the smooth muscle antibodies, the gamma globulins. I have it all listed right there. So just remember those labs. You can go ahead and grab those. And of course, please refer to your wonderful GI or hepatologist, because we love getting to the bottom of this. Or, you might need to be considering a liver biopsy, because Chelsea can attest to this as well. We will throw everything at them, the whole kitchen sink, every lab in the world, and it's either everything's abnormal or nothing's abnormal, and you're thinking, okay, I still can't explain this. So a lot of times those patients will end up with a liver biopsy. So if you have moderately elevated transaminases that are 5 to 15 times the upper limits of normal, again, you're going to do all those serologies that you would do for the mild, but you're going to add on the Hep A, do that ultrasound of your abdomen. If you see somebody with acute liver failure, which we'll mention in a minute, that requires urgency, consultation, referral to transplant center. We've had, I don't know how many people on our hospital list that we've actually had to transfer to a tertiary care facility, because we work in Reidsville, North Carolina, so it's a really small rural community. It's like, I don't know how many beds it is, but on the 3rd floor there's 40 beds. The ICU has 12, if that gives you an idea. So that makes us nervous when we see the patients with the INR creeping up, and then they're a little confused in that morning, and you're like, oh dear heavens. And so you start making those calls. Thankfully, we've had, not everything turns out to be a good story, but the past few that we've had end up transferring have had good outcomes. And actually just saw a guy in the clinic the other day. We're concerned that he has Wilson's disease, so that was pretty interesting.